Moving on to the next segment of today's session, that will be a guest lecture on common errors in medical practice. May I call upon Dr. Harsha Satish Chandra and Dr. P. Sudarshan to invite the speaker.
Next on the agenda is a guest lecture. The title of the lecture is Common Errors in Medical Practice, and it will be delivered by Dr. Ajoy Tewari. Dr. Tewari, MD, Internal Medicine, FICP, FRCP, FACP, Fellow Diabetes India, and Fellow Research Society for Study of Diabetes in India. He is currently working as a Director and Consultant Diabetologist, Jai Clinic and Diabetes Care Center in Lucknow. He is the Associate Professor of Medicine, HIMS Lucknow, and he is a Joint Secretary, American College of Physicians, India chapter. Over to you, Dr. Tewari.
Thank you, Chairpersons. And I think we have been discussing this topic throughout the conference. And yesterday, Dr. Andrew Elder from Edinburgh also talked about that if you are going to have a good clinical examination and a good history, we are likely to have less of errors in medical practice. So there is a problem with all of us, and that is what I call as the mammoth syndrome. We are always looking for subtle things, and we are missing the gross. So this is what is all about medicine, and this is how we are evolving over a period of time. So there could be simple patterns associated with the initial presentation, and they can be misidentified, like a rash of herpes zoster and a rash of poison oak, ureteric colic, but in fact may be a dissecting aneurysm, acute pericarditis or myocardial infarction. Then coming to the magnitude of the problem, do we have some studies to say that yes, this problem of medical errors exist? So there is a systematic analysis, and it identified that the errors in primary care among people with cancer, heart attack, meningitis, dementia, iron deficiency anemia, asthma, tremors in elderly, and human immunodeficiency virus. Then another study of 190 cases of diagnostic errors found that errors were more common in patients with pneumonia, decompensated congested heart failure, acute renal failure, cancer, or urinary tract infections. So now we come to what are the major areas that the WHO, World Health Organization, has identified as the reasons for diagnostic errors. So the most common were the missed cancers because it is an insidious onset and initial symptoms are not very conclusive. Then we can have infections that I'll be discussing in detail. Then we have cardiovascular disease. The initial symptoms may not be that apparent, and pediatric issues because we don't have the capacity to get the proper history and physical examinations. So infections are the major cause of diagnostic errors, and viral infections are often misdiagnosed as bacterial infections, and we all are doing it, and we are giving a lot of unnecessary antibiotics. We had a session on antibiotics and the rational use of antibiotics early on in the course of the day. Then the diagnosis of malaria can be particularly troublesome because key features such as fever are not very specific, and almost 10% of the cases of tuberculosis may be misdiagnosed due to misinterpretation of test results and failure to use basic diagnostic tools such as microbiology or imaging. Globally, diagnosis of children with pneumonia, dehydration from diarrhea, and malaria are often suboptimal. So these are the observations, and there are the studies to point to this thing. Now I'll be coming to a few cases of diagnostic failures, and this has come from CRICO. So CRICO is an organization which collects all the cases, and they make a summary, and because this can be accessed by everyone. So there is a 33-year-old obese patient with remote history of asthma and on oral contraceptives, and he presented to her primary care clinician with a 3-day complaint of right thigh pain, swelling, and red streaking of her skin. On examination, her right inguinal lymph nodes were enlarged and antibiotics were prescribed. 3 days later, she returned with complaint of new onset shortness of breath, chest pain, and rapid heart rate. The patient had diminished breath sounds. Her physician thought she was having an asthma because she had a history of asthma flare and advised her to continue antibiotics and asthma medications. Later the same day, the emergency personnel were called to the patient's home after she fell, and she was brought to a local emergency department where she quickly decompensated and died. And the autopsy revealed a large pulmonary thromboembolism. And this patient was on oral contraceptives. So being observant, getting a good history can give us great insights about the problems. Another thing could be misreading of an X-ray. So this is another case which has come from PRECO, and they said that a 55-year-old male was diagnosed by his primary care clinician with sinusitis and prescribed an antibiotic. 6 days later, he was evaluated with an urgent care clinic for shortness of breath, labored breathing, extreme fatigue, and chest pain with cough. The patient had temperature, a fast heart rate, and a low oxygen saturation. After he was treated with an aerosolized nebulizer, his oxygen saturation improved. Based on a negative interpretation of chest X-ray, the urgent care clinician diagnosed a viral upper respiratory tract infection and instructed the patient to see his family doctor the next day. 2 days later, the X-ray was read by a radiologist with impressions of pneumonia. The clinic called the patient and instructed him to go to his local emergency department for evaluation and treatment. Before he could go to the emergency department, the patient died of respiratory failure associated with pneumonia. And these cases are from the most developed nation, that is from the United States. So these are just eye-openers, what all could happen. And this is what I want to emphasize, that what we are seeing are just the tip of the iceberg. There are large number of cases of diagnostic errors. We do not discuss them. We do not come forward to discuss those things. That's why they go unreported. And nearly every person with experience of diagnostic, every person with experience a diagnostic error in their lifetime. So that's a very, very big statement, and we have to understand that. And the burden of diagnostic errors is 1 in 20 adults experience diagnostic error in outpatient settings each year. So what could be the factors associated with diagnostic errors? First could be the cognitive errors. So we all have mental shortcuts that we call as heuristics. We have made some formulas because we are all in the busy practice, so we make that this and this and this, so this will be this. So that is basically the cognitive biases. Then we can have systemic factors like inadequate access to patient records and fragmented care and time pressures. Then there are also problems associated with the communication issues, miscommunication or incomplete information sharing. Paucity of time, we don't elicit the entire history, or we do not get the entire thing in assessment. So this is now about the cognitive errors. So if you see this picture, it apparently is an old woman. But if you see the top one, now you will see that this is a young girl. So this is how we do the things, what we understand, and we are mostly guided by our gut feelings. And these gut feelings may be correct, but it is not efficient, and it is not reliable. And the predictive power is not very strong. So over a period of time, we develop those shortcuts, formulas, and we try to adapt to them, but we do not go to the proper things. So then we have got some few terms like the anchoring bias. Anchoring bias is the tendency of clinicians to stick with the initial impression even as new information becomes available. So this is with everyone. That has something to do with our egos, that yes, we have thought of this thing, so it has to be like that. Then confirmation bias is the tendency to selectively seek information that supports initial impressions. Then status quo bias is the tendency to stick with initial impressions as the number of new possible alternative diagnoses increases. Still we try to stick to what we have thought on the first go. Then premature closure. Premature closure is a failure to consider alternative diagnosis after the initial impression is formed. So always think, what else could it be? Whenever we are thinking, we always should be, as we are taught in our medical colleges, we all should think in the terms of differential diagnosis rather than a diagnosis, because that will give us better inputs. Then framing effect is that someone has formed some particular diagnosis beforehand, we try to stick to that thing. So that is the framing effect. So this is a very interesting study. They have found that 10% of the physicians are most likely to, if a patient has already been in a randomized trial, what they found, that if someone has formed a diagnosis beforehand, we try to stick to that particular diagnosis. So then coming to reduction of diagnostic errors, how we can do it. Consider using trigger tools. These trigger tools could be our patients or our colleagues who can, or the follow-up or the autopsy reports, those could be the triggering tools which could give us insights what we can get out of this. Then encourage and facilitate voluntary or prompted reports from the patients. That is very important. Encourage and facilitate error reporting from physicians. We can have WhatsApp groups, we can have institutional groups where these things can be reported. So these are the recommendations from the National Academy of Medicine Committee. They have said that we should have more effective teamwork, approach to identify, learn, and reduce diagnostic errors, establish a work system culture that supports rather than puts pressure on the physicians. That is very bad. We should come forward and report those errors because they will be helpful to the other colleagues. Design a consultative service for widespread use, enhance healthcare professional education and training. So training is a constant thing which has to be done throughout. Then system-based approaches are to build a no-blame culture. That is very important. If you are committing a medical error, that doesn't mean that every person, every human being can commit a mistake. So there should be a no-blame culture. Report diagnostic errors to prevent future errors. That is very important. Then shortly I will be moving you through some other things which can happen, like the dispensing error. Drugs that have a similar name or appearance. Wrong dose, wrong drug, or wrong patient. So if you see all these boxes, they all look similar, but they have constituents which may be very, very different. So this is very important that we have to understand. Safe dispensing procedure is important, separating drugs with similar name or appearance, because this is very common. Similar drugs, but they may have very deleterious effects on us. Then workload is very important. That is something which is very difficult in our practices in Southeast Asia, and awareness of high-risk drugs is very important, and they should be always put separately. Then administrative errors, it is mostly at the level of the paramedics. So you give an order to give an injection subcutaneous, and she inadvertently or he inadvertently gives it intramuscular or IV with lot of problems. Perinom injection given IV, streptomycin injection given IV, all these cases are happening almost very commonly. Then incorrect administration technique, that is very important, intradermal, subcutaneous. So this mixing up is always there. Administration of incorrect or expired preparations, they should be checked beforehand, and deliberation of violation of it. And at times, you will see the insulin dose was to be given, it was not given at all. So you may have high sugars, you were thinking that you have already been given the insulin, but it is not reported. Then coming to what could happen at our level, that is the prescription errors. So I define it with 3 Ds, that is the distraction, distortion, and discordance. So these are the 3 things. So distraction is very, very common in this modern world when we are flooded with social media and all those things. Constant pages are coming from different departments, attendance at meetings, the physicians doing administrative jobs, answering telephone calls, the social media is active throughout. So all these things are very important. So the strategies could be to set a time that after around a particular time the patient, the doctor has to write his notes, and that time he is not to take any calls. Structured way of patient care, penalizing physicians who continue to have too many medication errors, and then not answering patient calls until patient duties are completed. So this is very important. Then coming to very important thing, that is distortions, which is very common in our prescriptions in outpatient department. Poor writing, misunderstood symbols, the use of abbreviations or improper translations. Nurse or pharmacist to substitute. Even the pharmacy, they think that they know everything. They will read the SIMS book and they will replace. So that should not be the thing. Major errors could occur. Doctors should know what is available and limit the ordering from this list. So that is very important thing. And we all are very gifted people. So the studies have shown that gifted people often have bad handwriting because their brains are working faster than their hands. So we doctors are very gifted. Our brains are working faster than our hands. So we are blessed with poor handwritings. Very few of us, even including myself, we have very poor handwriting. So this is the open to perception. This is what was written. Other people's, they could not make anything out of this. But one person in the department, that is the nurse or the pharmacist, knows what the doctor has written. So that was an aspirin. So this is what it could be. Write complete and clear order with drug, name, dosage form, strength, dose, and route frequency. It should be legible. These things are not very common in these days because we have electronic medical records and we have electronic prescriptions, but still many of us are doing this. Then coming to a few comedy of errors. So this is vincristine 0.4 milligram. So intended dose was 0.4 milligram, interpreted as 4 milligram. From medication order should be written as 0.4 milligram. That is very important. Then another one, Humalog, 4 units, 2 units and 6 units, let us 14 units at bedtime. This was interpreted as, intended dose was 4 units in patient history, interpreted as 44 units, because U should not be written and it should be written as unit. So that is very important because these things can change the entire game. Then injection vancomycin level is less than 10, what was intended, and what was interpreted as 40. So it should be written as less than. Then potassium chloride 10 milligram, TPO QD in medication order, and it was taken as QID and should be written as daily. So these are the important things, and these things can be eliminated. To a bigger extent now with what we have got a lot of electronic medical records, we are doing electronic prescription writing, so these things are still, because many of our colleagues are still going for handwriting written prescriptions, so these things are important. And orders are usually written with hands, so this is important and it has to be understood. The practitioner or the pharmacist should never guess what the drug or dose is. It has to be asked. And now the next point comes is discordance. So these errors come in because there is a discordance between the nurse, the pharmacist, and the doctor. So this discordance is very important, and this communication between the doctor, the nurse, and the pharmacist should be an ongoing process. And at any point when they find that there is a disturbance, they should always revert back to the doctor to ask these things. And communication is the key. We have got so many social media forums with us. Now is the time when we can talk to our patients, we can talk to our teams, and can create good teams. Good, efficient intercommunication skills are important, and with these social media things, rather than going for other things, we can use it for our own good. Then physician distress is a very big problem, and that is what a lot of things are emanating out of this, the medical errors, because overworked doctors attending to large number of patients. So good team building, giving the responsibilities to other persons, meditations, yoga, all these things can help us to mitigate the physician's distress. Then I will end with this beautiful observation by a mother to her daughter. She said, marry someone who understands you like the pharmacist understands the doctor's handwriting. Thank you for patient hearing.
Thank you very much, Dr. Tewari, for that excellent talk, very thought-provoking. We can entertain one or two quick questions. May I ask you a question? Now you described about the importance of developing a non-blame culture in diagnosing medical error, in making medical errors come to light. So how will it impact legal issues when we try to sort of get people to come out with their mistakes? Will there be an issue with legal implications in this day and age?
Yeah. So that's a very good question, sir. And that is what I intended to show. It has to be an internal communication. Because if we are exposing these particular things to a wider audience, and with the legal system that we have, and the advocates and the lawyers are after us, so it's an internal system. We can have closed groups, the institutional groups, where we can discuss these things. But exposing these things to a wider public may have repercussions to our reputation as well as to the reputation of the institution that we are working.
Thank you.
Any more questions? Right, in the absence of questions, on behalf of Sri Lanka College of Internal Medicine, I take this opportunity to thank Dr. Tewari for that excellent and thought-provoking lecture. And may I ask my co-chair, Dr. Harsha Satish Chandra, to present the certificate of appreciation to Dr. Tewari, please.